Okay, so we are live here again, and today our goal pretty much is to record all of these lectures that we have for our coaching program. So, uh, yeah, I believe all we need to do now is get to it. I've prepared a whole bunch, and I've eaten, I've gone to the gym, so uh, nothing is remaining between us and then just doing the work. So it is time. Okay, here's what you got to know about TMS or transcranial magnetic stimulation. So this is something that's been becoming way more popular over the last 5 to 10 years. So it's definitely worth knowing something about. So it falls into class known as neuromodulation or non-invasive brain stimulation, and that's different because things like ECT or deep brain stimulation (DBS) are a lot more invasive and intensive than TMS is. So this has some FDA approved indications. So it's got MDD, it's got OCD, and then a little bit of smoking cessation as well. But the main reason is MDD and a little bit of OCD. But off label, there has been evidence showing that it's helpful for these conditions as well, too. So I have had patients use this off label. So, pretty much like the way that TMS works, and I'm not a TMS expert by any means. I've never actually done it myself before. I have seen another psychiatrist do it though. It was never an interest of mine, but it is becoming more popular. So if you work in like a neuromodulation clinic or an outpatient-based clinic, you may encounter this in your journey. So basically, the way it works is it delivers some like magnetic pulses to different brain regions, right? And so it's completely non-invasive at all. And so the main region that it targets is the left dorsal prefrontal cortex. So right here, right, the prefrontal cortex. So that's important because that's often an area that's associated with depression. So you can use high frequency pulses to the left prefrontal cortex, right? So that helps with excitability, and then the right one you use more low frequency pulses, um, and then that can help decrease hyperactivity. So that's what's used in the anxiety side. So depression side, high frequency; anxiety side, low frequency here. And so it's thought to like reset some of the mood circuits, and that's how it works with the magnetic pulses. So remember that in the brain, or just in general physics, magnetism and electricity are inversely related. So, right, for every magnetic pulse, there's an electric pulse, and every magnetic or electric pulse that creates a magnetic pulse with it. So that's how it works. And so it's thought to help with the mood circuits to help restore them, right, and to help normalize any kind of dysregulation that might be happening. So, and then when you do it repeatedly, that primes those circuits to neuroplasticity. So becoming more available to changing, right? So similar to, I mean, different mechanism, but a similar concept with, exercise or something like ketamine, for example, the neuroplasticity. That's the key part. Uh, so the way that the treatment typical protocol is that you have 5 sessions a week for about 4 to 6 weeks, right? So it's pretty intensive, right? So about 30 to 36 sessions. Each session's 20 to 40 minutes. Then once you do that, then you can switch on to a maintenance mode where you do 1 to 2 sessions per week. So definitely there's a commitment, right? Time commitment, location commitment there. But as I mentioned, it's an office treatment. Like plenty of outpatient psychiatrists do it, so there's no anesthesia or sedation required. So that's the nice part about it. And then now there's some like newer protocols that are coming. I'm not an expert in these ones too, but they're looking at theta burst stimulation or deep TMS, right? Where basically they're trying to do shorter sessions, um, and use something called H-coils to really get the deeper areas. So of note, this is what a TMS machine can look like, right? So the patient's sitting there, the TMS unit's here, right? The monitor, someone's monitoring it. Usually a psychiatrist, but then they'll train someone else to do that as well. And then, you have the TMS coil and then the magnetic field. And here's what it can look like, right? So pretty much they have the magnetic field, they put the cap on, and then that's what's doing the magnetic field stimulation. And then the technique. And then the technician here is able to pinpoint the specific areas where they want the magnetic pulse to go. It shocked me to being a rock star. LOL. Nah, you gotta work on that yourself, my friend. And so then there's that thing called the H-coil, which I mentioned, which basically gets the deeper level of stimulation, and it just hits more deeply. Now, its efficacy, so the response rate is about 50 to 60% for depression, which is pretty good. Antidepressant response rate is like a 33%, right? Remission rate, so about 30 to 40, so not bad either for depression, right? So it's most effective in people who failed a couple antidepressants. So that would be your ideal candidate, right? Let's say there's some treatment resistance. That's when you'd go to, okay, let me try TMS. Or if you have a patient who says, hey, I don't want any kind of medication. I just want to jump to this right away. But the improvement's gradual. It's not more rapid like ECT is. And so after 10 to 15 sessions, that's when you start noticing it. And you can stack it with existing antidepressants as well. So common side effects, right? So scalp discomfort, of course, headache at the stimulation site, right? Which makes total sense. People have reported jaw or facial twitching, lightheadedness or fatigue, very common as well too. Seizures, very rare. It's not really known for that. It doesn't really excite electrical activity that much, right? It's a lot more localized area. And thankfully, no memory impairment or sedation. So people can move on with their lives. It's not like ECT where it's a bigger event. Uh, so contraindication, right? Obviously, if there's any kind of metal in their head, right? So clips, cochlear implants, deep brain stimulators, right? Because the magnetic field will definitely interact with the metal. Just a history of seizure disorder or epilepsy, right? So it can be a contraindication, but the risk is low with this as long as you're well controlled. That's the most important thing. Substance use, of course, any kind of head trauma, any kind of bipolar disorder, because the electrical activity could stimulate that. Um, Pregnancy just hasn't been studied that well, so you definitely make a case by case basis. And any kind of severe psychosis or catatonia, because this is where you would consider ECT rather than TMS. So, in terms of monitoring, right, you'd monitor the scalp, muscle twitching, mood stability. You'd want to monitor psychiatric symptoms like all of these things, right? So that way you can make sure the person's actually getting better, measuring their functional improvement, making sure that they stick to the protocol, right? With this kind of in detailed protocol, it's really easy to miss days. And of course, bipolar, any kind of mood switches there. So you tend to see an improvement after 2 to 3 weeks, but then the peak effect comes at week 4 to 6. So this takes a little bit of time. Remember, it's a session each day. So it takes a little bit of time, right? So weeks to months, the benefit can last. So that's nice. But then if people start to relapse, then you have to do the maintenance TMS. Thankfully, there's no systemic metabolism, right? It's just purely electrical stimulation in the brain. And so you can combine it with other stuff to get the multimodal effect. So overall, what you got to know about TMS, especially if you refer a patient to it, it's non-invasive, non-sedating. It's ideal for people who have medication intolerance, pregnancy, or a poor adherence. Pregnancy, especially, I mentioned about pregnancy above, but then let's say the patient doesn't want any kind of medication. This is a safer alternative than psychotropic medication for a lot of people, or like a preference, right? There's no cognitive side effects or anesthesia needs, so it's very easy to do outpatient. So if anyone's working, right, they don't need downtime, they can just pop in, like for example during lunch period, and then leave. Uh, Anxious depression, it could be helpful, right? It's not proof for anxiety, but you can still target some of the anxiety as well. It's less effective if they have severe treatment resistant or psychotic features, right? That's when you might consider more ECT. And the nice thing is that insurance often covers it after failure of 1 to 2 antidepressants. So that's nice too. So overall, it can be an augmentation option, right? I'm not the biggest expert for TMS. I've never personally done it my self, but I have referred patients to it who I felt could benefit, who may have been doing helpful with medications, but they weren't doing fully. So, if you're in my case, suspect that's where you'll probably be encountering TMS most, is in its referral. So just knowing what it's about and who the right person is to refer is probably going to be the most high yield information for you. Minimum dose of lamotrigine for depression. I've had patients who benefit at 25, and then I have other patients who've benefited at 200. So there really is no minimum dose. I mean, minimum is 25, but anyone can, it just depends on the patient. So this one is transcranial magnetic stimulation, TMS. Now we're doing, okay, here's what you got to know about ECT, or electroconvulsive therapy. So this is also involved in neuromodulation and somatic treatment. So it's more of a intensive approach rather than TMS. So it doesn't really have FDA approval, but it is, used and accepted for a variety of different symptoms: major depressive disorder, bipolar, catatonia, schizophrenia, right? Especially if there's a catatonia or treatment resistance, significant suicidality, and treatment resistant mood disorders. So all of these are criteria where you use ECT. Basically, think of it like our most acute intervention psychiatrically. So, I've had patients where, like, for example, I had a mid, I think 40s female. She had schizophrenia, but she started to get up in catatonia. She was unresponsive to Ativan. I think her group home staff just found her catatonic in her home, and so then we did ECT with her, and that is what made the difference when Ativan didn't really do anything. So overall, like, the full mechanism is not fully understood, but it's got a couple theories, right? So the main one is that it's the seizure induction. So it induces a seizure, right? So that's why there's anesthesia that's given, is to prevent the actual physical seizing. So that's what helps reset those neural circuits, right, that are involved in mood and cognition. So kind of like think of it like a restart for the computer. Because it's altering that electrical activity, right? So it can enhance neuroplasticity and brain-derived neurotropic factor. It can increase GABA tone as well, so that's really important. Through like frontal limbic dysregulation, right? So sorry, it can normalize a lot of that too, because GABA is more calming, more relaxing. So this can be what make a difference in anxiety disorders or something like a catatonia, right, where normally the treatment is Ativan. It can help boost serotonin, dopamine, and noradrenergic activity, right, from electrical stimulation. And so they've done neuroimaging to see that there's increased connectivity in different areas. So, but this is the main mechanism by far. So it's the seizure induction, right? It's the reset. So typically you would do it about 3 times a week, and so that's the typical protocol I've seen both inpatient and outpatient. Usually about 6 to 12 treatments, and then but you can extend it. 9 to 12 is what I've typically seen, and then you can have a maintenance ECT, which you do once weekly to monthly to prevent a relapse, right? But then you would assess the need for that after doing your 9 to 12 treatments here. So as I mentioned, so there you need anesthesia and you need muscle relaxation, right? So that way the physical symptoms of the seizure are not present. So basically, there's an electrode that's placed in different areas of the brain. So I've never administered anesthesia or ECT myself. I've just observed it in a couple of patients. Can someone be catatonic for a few hours? Maybe. I've seen it for longer. I haven't seen it for just a few hours, though. Usually it lasts a little bit while. Like at least like a day. And so here's kind of what it looks like, right? You have the electrodes are placed, and then you have the shock where the shock is delivered. And then you have the shock where the shock is delivered. Right, so here's another picture of it, IRL. So basically, think of this like it's definitely a procedure, right? So because there's anesthesia, so you want them to be NPO. They do need anesthesia clearance, right? The patient has to be informed. They're given an anesthetic agent and a muscle relaxant. There's electrical stimulus, and that's what induces the seizure, right? And that's why it needs monitoring. So just think about it, instead of just an outpatient TMS, now this is probably in like a hospital setting with anesthesia involvement. So definitely a higher level of clearance that's required. And in post-procedure, right, there can be confusion, memory issues, headaches. So that's why there's some monitoring that occurs too. But the benefit is that the response rate is higher for depression and the remission rate, right? And so this is oftentimes considered a gold standard treatment, where if you've tried a bunch of stuff, then, or if you've tried meds and they've failed, then you can go to ECT. And so that can cause some rapid relief too. So that I think of it like it's more of an acute intervention, right? Because the antidepressants, they take a while to work. But there are some side effects, right? So, headache, nausea, think of like post-ictal confusion, memory loss. So that's a big one, both anterograde, meaning after the ECT, and retrograde, before the ECT. Sometimes there can be problems with memory, recall memory, autobiographical memory, and usually it gets better. It's a transient memory loss, but it is something to definitely be aware of. Some people, especially if they're older, they can have a delirium or prolonged confusion. And there could be potentially some injury if there's not proper muscle relaxation, like muscle injury. So, there's some relative contraindications, right? They're at a recent MI. May not be the best, right? Because now you're giving them anesthesia plus the shocking. The cardiac arrhythmia, right? Again, because of the shocking. You don't want to mess up the heart rhythm, right? Increased intracranial pressure and a recent stroke, right? You don't want to agitate anything that might be messed up there. Aneurysm, right? Any kind of pulmonary disease or unstable medical condition, because again, they're under anesthesia. And but these are all relative contraindications. These will require, if there's a psychiatrist experience with it, so usually they'll give clearance, and then as well as the anesthesiologist. And so monitoring wise, there's an EEG that's done, right, to measure the seizure, vital signs before and after, cognitive signs, right, make sure the patient's still with it, and then mood and psychiatric symptoms too. and possible med adjustments too. So normally, like with meds, people will take the meds, while they do ECT, right? It's not like you would just discontinue the medications, um, but you might need to adjust things, right? So you may not, if the patient takes a morning lithium or benzo, right? You may want to wait until they get their ECT session and then give it. So yeah, fastest acting, right? Life-saving catatonia, psychotic depression, mania. Um, it can be used in pregnancy, right? If there's a big pharmacologic risk, can be combined with meds for maintenance stuff, right? Hmm. Does increasing mental illness make you happier? That you will have more potential clients, higher rate? I mean, there's always going to be problems in the world, right? That's like saying, are police officers happier when there's more uh, crime? I wonder what he's typing. Yeah, so basically, what I'm typing is I realized I didn't, in my ECT lecture, I didn't cover the medications that you might continue in ECT versus might not. So I wanted to alter that. So it looks like they'll continue SSRIs, SNRIs, bupropion, antipsychotics, mirtazapine, benzos they'll hold, lithium they'll probably hold, oxcarbazepine they'll probably hold, MAOIs, TCAs, lithium, valproate, carbamazepine, bupropion, antipsychotics, mirtazapine. Yeah, so just added a section on which meds they might continue versus hold. So the ones that they'd mainly continue would be SSRIs, SNRIs, antipsychotics, right? Mirtazapine, trazodone, buspirone, hydroxyzine, propranolol. Bupropion you would continue, but unless it's a high dose, right? The main reason would be for the increased seizure risk. You don't want to throw it off. Benzos, you'd probably want to, they would hold. I mean, this all depends, but you would often hold it just because of too much sedation. Lithium, right? You may want to reduce some cognitive effects. Depakote, you may often hold it or reduce it. Because these are all anti-epileptics, right? So we want to not interfere with our seizures that we're inducing. So carbamazepine, right, would probably hold, same reason. Topamax, hold or reduce. MAOIs, these are just risky, so you might DC that. TCAs can have the arrhythmia risk, right? So just need to be careful. And then stimulants, you would just hold it just for the cardiac risks. So the main thing also remember with ECT is there's a lot of stigma. So it's called electroshock therapy and stuff, but it's very safe and it's controlled and it's evidence based. So it's quite the good treatment for it. Memory loss is real, but it is temporary and dose dependent, so that's nice. So basically, you want to consider it early in the process, especially if you're encountering a severe case. Because it can take approval. It's like an ECT certified psychiatrist has to approve it. The anesthesia has to do it. You have to set it up. Like there's some friction in getting this already. Like the way that it worked in my hospital was that, let's say we had an inpatient who needed ECT, then we would consult the ECT psychiatrist. This would be a special psych who does ECT, and then they would go and assess the patient and decide, okay, do we want to admit this patient for ECT or not? And so that's what we would do. Yeah, and so yeah, definitely consent is important too. The person has to be aware of it. Any recommendations for best antidepressants in dry eye? Yeah, so these antidepressants, or these glasses for sure. So you want to wear these glasses. Basically, you would also want to avoid any anticholinergic antidepressants. So mostly SSRIs other than Paxil are pretty safe. But I would get these glasses. I just read an article saying that smelling a different essential oil each night over 7 nights can reduce long term can reduce risk of Alzheimer's. Can it be true? Maybe I have no idea. I mean, I'm definitely not an Alzheimer's expert, so I don't know. But I think that essential oils could help you with sleep, and if they help you with sleep, then that's definitely helpful. Okay, so that was electroconvulsive therapy. So that's ECT. So we just did that. Whew, okay. So now what we need to do is deep brain stimulation. Psychiatrist prescribed me Lamictal. Does that mean I'm bipolar? No, it's used for mood lability too. Hey, what's up? I have a confession. Nice. I don't know if this is a place for confessions. I can't, I can't really offer you any kind of religious saving. All right, here's what we got to know about DBS, deep brain stimulation. So this is a neuromodulation technique as well, but think of this as more of an invasive one, right? So if TMS is least invasive, ECT is middle, this is the most invasive. This requires surgery. So this has been approved for Parkinson's, tremors, dystonias. That's what I've seen it for neurology. So the one time I saw a DBS case was I was in my neurology rotation, and the person had extreme Parkinson's, and no meds were covering it. So the neurologist and the neurosurgeon came together to get the patient DBS, deep brain stimulation, for the Parkinson's. So it's also been used in OCD, but this is more of a like very rare kind of cases. They did this thing called the humanitarian device exemption, where basically it's like the patient has to be so severe and failed everything else that would approve this for DBS. But off-label like psychosis or treatment-resistant depression, Tourette's, addiction, and AN as well too. So it can be used for that. But these are all very rare and investigational things. Like DBS is not a common or even a very like go-to for any kind of psychiatric condition, because it's surgical implantation of electrodes into the deep brain structures, right? And then there's a pulse generator, the neurostimulator, that works with it. So here's like the perfect example, right? So you have your lead and then the extension, right? And then literally there's a neurostimulator that's giving the electrical signals over to the certain brain areas. So it's definitely not a thing that we would do lightly. So, so basically, it targets different areas. So it could target the ventral capsule, ventral striatum, the nucleus accumbens, subcallosal cingulate gyrus. Like this requires an expert to do. Like you would need a neurosurgeon to do this. You would need a psychiatrist who's very, very well versed in this DBS type of stuff. Like this would not be a like that any psychiatrist could do or any psychiatric provider could do. So you would need specialized training for this. So it's thought to normalize some frontal striatal limbic circuitry, right? So basically some of the OCD circuitry that occurs, right? And so, thought to improve mood, reduce the compulsions, and to help regulate mood as well. So as I mentioned, so you need a multidisciplinary team, right? You need the pre-op imaging, MRI, CT. You need the electrodes implanted, the battery that has to be placed, and then, the device has to be programmable too. And it's just adjusted as well. So the effects are more gradual. So it's not like you notice immediately, but like you implant it and slowly over time, you would adjust the electrical stimulation of it. So yeah, as I said, so it's mainly for select research centers. So it's not a very common thing. But they have found a 50 to 60 response rate. So there's definitely some evidence for it and some support, right? So depression, there's some variable response. It's outcomes with patients who have chronic, severe functionally impairing symptoms. The effects could be delayed too, right? So it takes weeks to months post-activation because you have to titrate. It's not like you just shock them like an ECT. You titrate it accordingly. So obviously you have surgical risks that can come from it. Any kind of cognitive effects, right? Apathy, hypomania, impulsivity, depression, headache, dizziness, device malfunction, and then they got to replace the battery every 3 to 5 years too. But I mean, I guess it depends on the unit that they use. So definitely not something that we take lightly, right? So any kind of surgery contraindications can be problem, active psychosis, bipolar disorder that's uncontrolled, right? If they're not the compliant patient, that can be a problem. Kind of bleeding disorder. Maybe if they've tried some previous neuromodulation, then that could be an issue as well too. And so you would definitely want to monitor the recovery, track their symptoms, um, behavioral effects you want to check, the battery life they'd want to check, and then there'd be a lot of coordination too between psych and neurosurge. So yeah, obviously there's no absorption or anything, so that's nice as well too, but it takes weeks to months. So overall, considered a last line therapy, definitely not something that you would rush to immediately. They've have to have tried a whole bunch of different stuff, right? But it's reversible, it's more adjustable, right? So it's able to tweak it longer and it's easier. Like once you get it all set up, then the maintenance is easier. You don't have to really come in as often. It just kind of works on its own once it's all set up. But it takes a whole time to set up, right? And the response may or may not be the best. So overall, it's mainly in the specialty centers that do that. So definitely not something you're probably going to see or refer unless the patient is very, very severe and like you've tried pretty much everything else. Whew. Love your dedication to brain science. Keep up the good work. Appreciate. How do you know if you have a mental disorder? Well, if you're having mental health problems, you probably know that, and then you get evaluated by a psychiatrist. Deep brain stimulation, so DBS. Perfect. So we did that one. HT1A. Okay, so here's what we gotta know about buspirone or Buspar. So this is an anxiolytic. Basically, it's a non-benzo that's used for anxiety. So the way it works is it's a partial agonist at the 5-HT1A receptor. So there's a presynaptic and a postsynaptic component of that. So basically, the presynaptic wise, right? So what it does is it hits it. So basically, this actually inhibits serotonin release, but over time, as it keeps stimulating it, it kind of like poops out, and that ends up releasing more serotonin. So that helps. So that gives some anxiety benefit. And then the postsynaptic, so that's what enhances the serotonergic transmission over time too. So presynaptic, postsynaptic 5-HT1A. It doesn't affect GABA at all, so that's why there's no sedation or any kind of problems with that or any addiction risk. A little bit of deep dopamine activity, but it's not like really a clinical thing. So main thing, FDA approvals for GAD, but then it's often added to SSRIs and SNRIs to help with GAD as well. Uh, it can be used for depression. It can be used for some sexual dysfunction as well too. There's some evidence that can treat that basically by reducing some of that serotonergic activity. So there's less flooding of serotonin that an SSRI does. So it helps to modulate that and to normalize the serotonin activity a little bit, and anxiety and bipolar. So basically, this dose starts about 7.5 twice a day. You go to about 15 or 30 twice a day or 3 times a day. Twice a day is generally easier and enough, right? Usually max dose is about 60 milligrams, and you can just titrate up every couple days till you get there. But the main thing is you have to take it consistently for the effect. It's not a PRN medication; it's a daily medication, right? BID to TID. So it's important to let the patient know about this. So it takes a little bit of time, like 2 to 4 weeks. It's not like something that'll hit immediately. So it's not something that's useful for acute anxiety or panic attacks, but over time, it will modulate the serotonin benefit. So, you got to tell the patient, especially if the patient is thinking it's going to be like a benzo that they've tried before. Like, no, it's not the same. Luckily, it's pretty cheap, widely available 5, 7.5, 10, 15, and 30 milligram doses. So, you could get the patient up to 30 milligrams twice a day, and you're good there. Side effects doesn't tend to be a big side effect medication, but dizziness, headache, nausea, nervous, just lightheadedness can be common. These ones are some of the less common ones. Not really sedative, not much cognitive impairment there, and not much withdrawal either, so that's nice. Um, but it's broken down by CYP3A4. So some CYP3A4 inhibitors could increase the dose of it, right? So thankfully, it can be used with SSRIs or SNRIs, very common done. So it's known that pregnancy is category B, so that's nice, very tolerable in pregnancy. So that's the good. So when would you use this? So this would be for the GAD patient. Uh, who doesn't need rapid relief for sedation, but like over time, they want something that's non-addictive. Um, they want you've had a patient who's had some benefit from an SSRI or SNRI, and you just want to target the anxiety a little bit further, right? If there's a history of substance use disorder, then you can consider this, and if you want to do anxiety management long term too. But if the patient needs rapid release, then you want to avoid it. If they can't stick to a med regimen, they have to take this BID, so that's important. And if they're already on multiple serotonin agents, so just need to be careful about that. And if there's severe liver impairment because it's metabolized hepatically, CYP3A4. But overall, like decent med. I've had attendings have mixed opinions on this. I have some say that it works decently. I've had others say that it is pretty much like candy, like it's useless. I remember I had one attending who was very adamant that this was kind of useless. I fall more in the middle. Like I don't think it's useless, but I don't think it's like a magical thing. So for mild to moderate anxiety, like that's when I would consider it. But if there's severe anxiety or OCD, then I think there's other stronger options available than this. Oof. Can diazepam cause insomnia and weird dreams? Yeah, it can definitely cause that. Weird dreams. Do I combine short and long acting stimulants? I do, yeah. I think I'm getting an allergic reaction to my cat again. So I am going to get some allergy medication and BRB. It's fine though. I'll take you with me. And do you have any ways to reduce stress or anxiety? Yeah. I mean, meds, therapy, diet, lifestyle, exercise, remove stressors, eat clean, meditation, CBT practices. Basically, you just have to figure out what works for you. That's the most important thing. Before problems, right? Figure out what you should do. You should do the find community. You're saying I would find community? I don't think I would find community when I'm going live. Psychiatry on tour, that's funny. Okay, perfect. So that one was buspirone, buse. Well, we just talked about buspirone. That's a good med for anxiety. Literally. And I'm about to give a I'm about to, what allergy meds do I use? I use, cetirizine, Zyrtec. All right, now we're about to talk about another anxiety med. Okay, here's what we got to know about hydroxyzine or Vistaril / Atarax. Excuse me. So this is a antihistamine that also has benefits. Excuse me. Let me just restart that. Okay, here's what we got to know about hydroxyzine or Vistaril or Atarax. So this is an antihistamine that has some anxiety benefits. So basically, it's an H1 receptor antagonist. So that's what gives it a sedative and calming effect, right? That's what the majority of side effects that you hear about hydroxyzine and Vistaril is that it makes them sleepy. But the other one that helps them with anxiety is the 5-HT2A receptor antagonism. So that's what gives it some of the anxiolytic and the serotonergic effects. So basically, the way that 5-HT2A activation works is it helps to increase glutamate, which can increase anxiety, sleep, hallucinations, libido. So that's what stimulation of this serotonin receptor can do. So by blocking this specific receptor, that's when you can get the anxiolytic and the anti-serotonergic benefits. So there's a little bit of anticholinergic activity as well too. So that's what can cause side effects like dry mouth and sedation. So you just got to be careful for that. And since there's no GABA receptor affinity, that's what gives it non-addictive properties. So it's approved for anxiety, itching, nausea, vomiting, and sedation as well. So off-label, right? So it's as I mentioned, for short-term treatment for generalized anxiety disorder, for insomnia, I use this plenty of in the prison for anxiety at night or for insomnia. for panic disorder or PTSD, right, to get rid of panic attacks, situational anxiety, and to help when you're tapering off a benzo as well. I've done this too. So, the dose that you give, generally you'd start at about 25 to 50 milligrams. It can go up to 4 times a day, right? So 200 milligrams per day. Uh, but I have given higher level doses before, like 100 milligrams as well. So I'll add that in. Yeah, so for like a resistant patient, so for example, in the prison population, right? That's where I really want to make sure someone, like, if they tend to have higher treatment resistance, and I want to make sure they go to sleep. So I'll do 100 milligrams. Then same thing with insomnia too, 25 to 50, and then 100 milligrams if severe too. Uh, Onset usually about 30 to 60 minutes, and lasts about 4 to 6 hours. So it kicks in relatively quickly too, which is nice. In terms of dosage form, so it comes in at 25, 50, and 100. That's the capsules. The capsules are called Visceral, and then the tablets are called Atarax. So 10, 25, and 50. So this can be nice because I've had sometimes kids or teens take the 10 milligrams, and so that can be enough for them. Um, there's an oral solution and an IM, but I've never pretty much seen this used. It's just not like, if I'm trying to treat agitation, I would use stronger stuff than IM Visceral. And if I'm trying to get anticholinergic effects, then I would use Benadryl, like for EPS. So about $4 to $15 a month, so relatively quick, or relatively cheap, sorry. So it's used as an anxiolytic, PRN, no abuse potential, short term or adjunctively. You just have to be wary of the sedation. That's the biggest thing, the drowsiness. So you're trying to find the balance between giving an anxiety benefit but not being too sedating. So it really just depends patient to patient. Be mindful of anticholinergic effects as well too. Right, so constipation, urinary retention, and then also be mindful if you're stacking it with another anticholinergic, for example, like antipsychotic, like Seroquel, Zyprexa, or Paxil. So, the rare stuff is just QT prolongation or some agitation in kids. Just be mindful of that. There can be some sedation with alcohol, right? So you just want to be mindful of other things that can cause CNS depression. Yeah, pregnancy category C. So it's obviously considered safer than benzos, so you can use it. Yeah, so the main thing to know about this is the PRN anxiety relief. That's the main thing, especially if there's substance use history. You want something that's non-addictive, or you want to help with insomnia. So that's pretty much it. You can use it short-term or adjunctively. I've had some patients on it scheduled, but that's not the ideal use for it. Can you snort trazodone? I would not snort trazodone, no. Whew. Okay. All right, so that was hydroxyzine slash Visceral. All right, so now what we got to do is okay, so here's what we got to know about propranolol or Inderol. So this is a beta blocker, and it's used very frequently in psychiatry to treat anxiety. And so the way it works is it treats physical anxiety. So the main thing that we're relying on is this B1 agonism. So the beta 1 agonism, that's in the cardiac system. So basically, this normally will increase your heart rate and your contractility. So by blocking it, we slow down the heart rate, and it reduces heart rate, reduces blood pressure. So if someone's having like chest palpitations or the heart's beating really fast, um, they get like all peripherally tingly. It just slows a lot of that down. And it can also cause bronchoconstriction as well, because normally Bu2 agonism causes bronchodilation. Yeah, so pretty much right. So here you're at the B1 agonism. So antagonisms, right? So that's where you decrease the heart rate, decrease contractility, and then those two combined will end up decreasing the blood pressure. And then you also cause bronchoconstriction from this as well. So think about it as like, you're just calming down the sympathetic nervous system, right? Tachycardia, tremors, and sweating. So the main effects are peripheral, right? It's not central, but it still does cross more than some of the other beta blockers because it's lipophilic. So it can have some central anxiety effects, but the main thing is the peripherally, right? So that's why if you use it for performance anxiety, and it's also helpful like for some people, especially if they have panic attacks where their heart's really pounding. You just want to be mindful in panic attacks where uh, they have trouble breathing, right? Because you don't want to give them any more bronchoconstriction. So, I mean, it's approved for all these medical conditions. So that's why this can be a nice adjunct if, let's say, you have a patient who has anxiety and hypertension, for example, then you could start propranolol with them. So, for example, I have a patient who has some anxiety and she's already on a blood pressure med. So I'm trying to confer with her PCP to get her off her losartan so that way we can start propranolol and then address both those things as once. So yeah, performance anxiety, public speaking, situational, PTSD, hyperarousal, right? So that's a big one. Any kind of lithium tremor, akathisia, panic attacks, right? So I'd be mindful of breathing. And then aggression and impulsivity. So this can be useful for that. So dosing guidelines. So about 10 to 40 milligrams, you can give 30, 60 minutes before you have an event. Typical dose might be 20. So that's what I'll usually prescribe. And then I'll tell the patient, okay, try half first. And if half doesn't work, then try the full. And then if that doesn't work, try like a full and a half. So that way they can titrate the tablets to what they need to. There's also so then you can also give it chronically as well too. So, you could just like dose it BID. So especially for a patient who, you want them on it regularly. There's also an extended release version, but be mindful that the extended release version starts at 60 milligrams. So may not be the best unless you know that they can tolerate that dose. And like I remember I had one case where I think they were on like 20 or 30, and then I said, okay, they had a lot of anxiety, so I said, okay, let's go to the XR. So since the lowest was 60, I started them, and then they got really lightheaded and almost passed out. So you just want to be careful of jumping to the XR unless you've established some tolerability on some of these doses here. Luckily, it's pretty cheap, so that's nice. Yeah, so the main reasons preferred over other beta blockers is because of the lipophilicity, right? It causes the blood-brain barrier and also helps with tremor. But you want to avoid it for people who have asthma or COPD, right? Or breathing problems and panic attacks. If they're diabetics, so just be aware that it could blunt some of that hypoglycemia awareness, right? So that's key too, right? Like some of those signs that they get from hypoglycemia. So, people use it situationally, but it can be used daily too. Right, sometimes daily. And it can help with tremor as well. And in terms of side effects, right? So bradycardia, fatigue, dizziness, cold, less common, right? So These ones I've never, I mean, hypotension I've seen, of course, but, you know, these ones I've never personally seen. I'm gonna move that here. Bronchospasm, right? So just want to be careful of that. And these are ones are rare too. So, yeah, and then just random trying to kind of peripheral arterial disease or something like that, right? Because you're already reducing blood flow. So, basically you get some smooth vascular contraction because you're slowing down the heart rate. So because the blood pressure decreases, there's vascular contraction that happens to balance that out. So you just need to be careful of that. Yeah, and then just be careful with other antihypertensives, right? Like that patient that I mentioned, or other cardiac things, or other things that interact with the heart, right? Anything that affects like any kind of heart medication, right? Like antiarrhythmics, you know, you want to be careful. Yeah, so just recognize that. Yeah, so oh yeah, and then the other thing, right? So if you have a beta agonist rescue inhaler, for example, albuterol, then it could counteract that. So just need to be cognizant of this. Yeah, but overall, you use it for performance anxiety. If they have cardiac physical symptoms of anxiety, you know, you want something that doesn't have addiction risk. If they have hypertension, if you want to use it for tremor, akathisia, right? So this is definitely a decent medication. Like you should be aware of this in your arsenal, and it does have its use in the right situations. Whew. It's like, I am an MD. Yeah. Actually, what I'm going to do is I'm going to take a little bit of break. Charge my phone a little bit and then come back. How can I make an appointment? Best way to make an appointment is to it's in my bio. So that's the best place to make an appointment. But yeah, I'm going to take a little break and then come back.